Hi, now we're going to talk about hypothyroidism. Hypothyroidism affects women more frequently than men and occurs between the ages most often between 40 to 70. We know that the prevalence does increase with age. This disease results in suboptimal levels of thyroid hormone. Thyroid deficiency can affect all body functions and can range from mild to subclinical forms to myxedemia, which is a severe deficiency discussed later in the lecture. An advanced life-threatening form, this is myxedemia, is most common cause of hypothyroidism in adults is autoimmune thyroiditis, Hashimoto's disease, in which the immune system attacks the thyroid gland. Hypothyroidism is an underactive thyroid gland. It means that the thyroid gland can't make up enough thyroid hormone to keep your body running. People with hypothyroidism have too little thyroid hormone in their blood. So remember, as we discussed before, the difference between primary and secondary. So primary is related to destruction of the thyroid tissue itself. Secondary means that there's something going on at pituitary that decreases the secretion of TSH. Other causes of hypothyroidism that you might hear of, we talked about Hashimoto's, post-Graves' disease. Another could be atrophy of the thyroid gland with aging. Therapy for hyperthyroidism, radioactive iodine, a patient that's had a thyroidectomy, medications like lithium, iodine compounds, antithyroid medications, radiation to the head and neck for when that person may have head and neck cancer, lymphoma disease that has infiltrated to the thyroid, and someone that has iodine deficiency and iodine excess. So what are the clinical manifestations? Well, they can vary. Extreme fatigue will make it difficult for the patient to complete a full day's work. They may report hair loss, brittle nails, dry skin. They will have menstrual disturbances. They can be anywhere from menorrhea to amenorrhea. In severe hypothyroidism, they'll have subnormal body temperatures, low pulse rate. They may gain weight. Skin becomes thickened. Hair thins out, falls out. Face becomes expressionless and mask-like. Complaints of being cold even in a warm environment. May be irritable. Emotional responses are kind of subdued. Mental processes become dulled. Speech can become slow. They may have characteristics of dementia. Increased ventilation and sleep apnea can occur, or inadequate ventilation and sleep apnea can occur. May develop pleural effusions, pericardial effusions. Severe hypothyroidism is associated with elevated serum cholesterol levels. So then this puts the person at risk for coronary artery disease. Patients with unrecognized hypothyroidism who undergo surgery are at risk for intraoperative hypotension, postoperative heart failure, and altered mental status. This is a picture of a person that's had severe long-standing hypothyroidism. And what they display is what they call myxedemia. This is going to lead to impaired self-image. They develop a dull, puffy skin, coarse, sparse hair, periorbital edema, and a prominent tongue. Here's another cartoon for you guys to bring it all down in one little picture, okay, of the symptoms of hypothyroidism. So here you see the hair loss, apathy, lethargy, thick tongue, slow speech, anorexia, dull, blank expression, facial eyelid edema, receding hairline. Now remember down here we talk about the late clinical symptoms, okay? These are, we'd rather not get there, okay? We'd rather control it before. So remember we talked about complications, the myasthenia, coma. Now one thing with that is it can be precipitated by infection, drugs, especially opioids, tranquilizers, and barbiturates, exposure to cold. It is characterized by subnormal temperatures, hypotension, and hypoventilation. Condition may develop because patients never been diagnosed with hypothyroidism and they come in with these kind of symptoms. Can be precipitated by infection or other systemic diseases or by the use of these sedatives or opioid analgesics. Patients may also experience myasthenia coma if they forget to take their thyroid replacement medications. This condition most often occurs in older women during the winter months and appears to be precipitated by cold. But however, the disorder can affect any group, but we do see it more often in that group. In myasthenia coma, the patients initially show signs of depression, diminished cognitive status, lethargy, and somnolence. This increased lethargy may progress to stupor. It leads to a decrease in respiratory drive, resulting in alveoli hypoventilation, progressive CO2 retention, narcosis, and coma. All not good for our patients, right, guys? We don't want that. Coma is not a good thing, nor is progressive CO2 retention. They also may exhibit hypernatremia, hypoglycemia, hypoventilation, hypotension, bradycardia, and hypothermia. So you see everything's low, right? Okay, so that's kind of easy to remember. Symptoms along with cardiovascular collapse and shock require aggressive and intensive therapy and hemodynamic therapy for this patient to survive. And that's what we want. We want our patients to survive, right? Although there has been a decline in mortality rates over the past 2 decades due to early intervention and improved therapies, the mortality rate remains high as 30 to 40% with patients that come in with this. The greatest risk population that's at greater risk is the older adults, individuals that have history of cardiac complications, patients that come in reduced consciousness, persistent hypothermia, and are further complicated because they have sepsis. Diagnostic studies that we would do for this population, again, we're going to do lab findings. You're probably going to see an elevated cholesterol, triglycerides. They're going to be anemic. Elevated TSH as well. What are our objectives of treatment for hypothyroidism? Well, we want to restore our normal metabolic state by replacing the missing hormone. Prevention of the disease progression and complications. Medical treatment is going to include something like a synthetic levothyroxine, like Synthroid, is most commonly prescribed. Remember, with Synthroid, it should be given at the same time every day. And usually, you want to give it before breakfast on an empty stomach. The symptoms of myasthenia will disappear and normal metabolic activity is resumed once they achieve therapeutic regime. Therapeutic levels with that Synthroid. If the disease progresses to myasthenia coma, remember this is rare, so it doesn't happen very often. IV administration of T4 and T3 are recommended rather than T4 alone. T4 is administered IV until the patient is able to take T4 in an oral form. T3 is administered IV until the patient is stable. Administration of high-dose glucocorticoids like hydrocortisone every 8 to 12 hours for 24 hours, followed by low dose, is recommended until coexisting adrenal insufficiency is ruled out. You're going to take serum T4, TSH, and cortisol levels before and after administration of these hormones. If the patient is exhibiting other conditions, they need to be treated as well. For example, if they have hyponatremia, we're going to treat that. If their blood pressure is low, we're giving them medications to bring up their blood pressure. Same thing with like heart rate, bradycardia, all that kind of stuff. Potential nursing diagnosis. Activity intolerance related to fatigue and depressed cognitive status. Our goal would be to increase participation in activities and increase independence. So we're going to promote independence with self-care activities. Another potential diagnosis is risk for imbalanced body temperature. So our goal would be to maintain normal body temperature. So how are we going to do that? Well, they're cold. We're going to give them an extra blanket. Avoid or discourage use of heating pads. Monitor patient's body temperature and report any decrease to their baseline. We also want to protect them from colds and drafts. Another potential diagnosis could be constipation. So we're going to encourage fluid intake. And if they're on a fluid restriction, we may be limited with that, but we're going to encourage it as much as we can. We're going to provide foods high in fiber. We're going to instruct patient with about foods that are high in water content. Monitor bowel function. Increase mobility. And encourage patient to use laxatives and enemas sparingly. You don't want them to use. We'd rather fluids and ambulation. Another potential diagnosis could be deficient knowledge about their therapeutic regime and lifelong thyroid replacement. So we definitely want them to understand that they have to take this medication for the rest of their lives. They may have another potential could be ineffective breathing pattern related to decreased ventilation. So we would want to monitor them for their breathing. And you may also, if your patient's experiencing confusion, you could also have a nursing diagnosis of acute confusion. Acute intervention if the patient's admitted with myasthenia coma. Remember we said that this is going to be a critical situation. They're going to be in the ICU. They'd most likely be on a ventilator, cardiac monitoring. They're going to get the IV thyroid replacement. Hyponatremic, we're going to be giving them replacement and try to get that sodium up. Remember, we have to get the sodium up kind of gradually. We don't want to jack it up too quickly. Going to monitor core body temperatures. We're going to avoid the use of hypnotic sedatives or analgesic agents. They're going to be on intake and output, vital signs, observing for mental status, alertness, eyes and nose, weights, those kind of things. So when they're ready to go home, what are we teaching them about? Well, their meds, right? And symptoms of overdose, okay? So when do they notify the physician? That's common sense, right? Whenever we send someone home, when should I call the doctor? And what are my medications for? And if there are any restrictions. That would be a big part of what you need. And remember, you want to provide written handouts because your patient can get pretty overwhelmed, right? They could definitely be, they've been through a lot here. You also want to teach the patient about toxic signs and symptoms of these drugs because thyroid preps can potentiate the effects of other common drugs they might be placed on eventually. So like if they're on Coumadin, they need to be aware of it. If they're on Digitalis, they need to be aware of it. So very important to manage that. Okay, so here's a little review side by side. You've got the lady on the one side, hypofunction of the thyroid, and you've got hyperfunction on the other side. So you can look at the differences, okay? So just remember, one is too much thyroid hormone circulating, one is too little, and what occurs there. All right, last question. What medication blocks the synthesis of thyroid hormone? And the answer would be the methylmelazole, the MMI, right? And that's it for hypothyroidism. And